Good morning, everyone. I'm Shana Varner with PHCA. Thank you so much for joining us for today's webinar, Improving Dental Care in Skilled Nursing Facilities. A few quick updates to share before we get started this morning. This webinar is being recorded and will be made available on the PHCA website following today's session. Additionally, today's webinar has been approved for 1 continuing education credit for all attendees. For those who provided a NAB number, credits will be uploaded shortly. We'll also be sharing certificates with those in attendance. Following today's webinar, you'll receive a survey. Your feedback is very important to us and our presenters, so we hope that you'll take a moment to complete that survey at the end of today's webinar. As we begin today, all attendees will be in listen-only mode. Please feel free to submit your questions via the chat box on your screen. We'll make sure that we answer as many of those questions as possible at the end of today's presentation. So now we'll go ahead and get started, and I will turn things over to our presenter today, John Whitman. John? John, it looks like you might be self-muted.
Oh, there we go. Is that better?
There you are. Thank you so much.
All right. Thank you. Good morning, everybody. My name is John Whitman, and I have been actively involved in senior care services my whole career. I started as a nursing home administrator way back in the early 80s, and then went into consulting and research and teaching. And recently, about 9 months ago, took over the CEO position of Chandler Hall in Newtown, a senior care facility with independent living, memory care, personal care and nursing home beds and a hospice unit. So I've come back to my roots and I'm very excited about it. Dental care has always been a particular interest of mine because it's, when I first ran a facility back in the early 80s, it was a real issue and concern, and there wasn't much in the way of availability. It was sort of the forgotten service, if you would, that just didn't get a lot of attention from anybody. And in 2008, I did a CMS study looking at the availability of dental care and nursing home care throughout the industry. And we're going to talk a little bit about that today and some of the improvements that have happened since then and where we can go. So but first, let me start by saying, I'm moving to the next slide and it's not letting me move to the next slide. Oh, there we go. This is a picture of one of my earliest residents from when I started as administrator. Her name was Gertie. You know, you look at her and she is the typical nursing home resident, if you would, old and frail and in a wheelchair. But she was one of the smartest women I've ever met. She was a school teacher for many, many years. She was a principal for many, many years, just sharp as a tack. And I used to have lunch with her and play Scrabble a couple of days a week, and she always beat the pants off me. But I show her a picture. I've been doing this for 30 years because even though we talk about rules and regulations and reimbursement and operational issues, you know, at the end of the day, everything we're doing is for the patients that we serve, for the Gerties of the world, if you would. So I always put her picture up there to remind us that despite all the other issues we get involved with, at the end of the day, it all comes back to our residents. So forgive I'm just coming out of a flu and I still have a little bit of a cough, so I apologize. But the goals for today is to understand, you know, the reality of limited dental care services or nursing homes across the country and what the impact on quality and cost that really has. We're going to explore some of the current options being used to provide dental care to nursing homes. And with each of them, we're going to talk a little bit about what's good, what's bad, and what's, for lack of better words, ugly about them. So the strengths and the weaknesses we'll look at. I also was approached by a dentist out of the University of Penn with a new device that he's developed that is pretty significant, and it looks like it could help improve the level of daily brushing in nursing homes, which is an important part of that quality factor. And we're going to talk about that. And any of you that might be interested, he's looking for participating facilities right now to be involved in a pilot project. So I'll get into more details on that as we get forward. But before we start, it's important to, I'm a big believer in humor in healthcare, particularly in senior care. So I like to show this at the start. we'll let this run through and then I'll comment on why I think it's important. Mhm. I think that's important to start with because it shows that, the way we've done things in the past isn't necessarily the best way. And even though we try oftentimes to do the best, it doesn't always turn out that way. I just love the way the guy just keeps hitting the button, thinking it's going to light his car, the one he's cleaned off, instead of the one that it does. So good way to, thank God we're in springtime as well. All right, the current state of dental care in our nation's facilities. In that study in 2008, I mean, it was really unbelievable what we found. And we surveyed dentists and doctors in nursing homes and CNAs, residents and families in a whole variety of states. And it was pretty clear that dental care was really limited. I only found one good example in Minneapolis, and we'll talk about that in a little bit. But dental care was extremely fragmented and very, very limited. And brushing teeth was not even on the CNA's to-do list on a daily basis, and it rarely happened. Finding dentists to come into a nursing home back then was challenging at best. I mean, it was really a difficult process. And you can ask yourself why, and this one simple reason. I still teach at the Wharton School in the MBA Healthcare Management Program. And one of the things I tell my students all the time is anytime you're asked a question in healthcare and you don't know the answer, if you say money, 9 times out of 10, you will be right. And the reason we couldn't find dentists back then to work in nursing homes is because they weren't getting paid. I mean, the reimbursement was horrendous. Medicare only paid for certain things and paid at very poor rates. I remember calling the Department of Health in New Jersey back then and to get the price of what a dentist would be reimbursed for extracting a tooth in a nursing home. So think about this, the dentist is going to leave his office, travel who knows how long to get to the nursing home. He's going to work on a resident, probably in their bed in the nursing home, and then he's going to extract the tooth, do whatever he has to do, and he's going to come back, take his tools, have them re-sterilized, and then submit a bill to the state of New Jersey. And if he got paid first time, which was really unusual back then, he usually had to resubmit it a couple times, but they were reimbursing a total of $18 to extract a tooth. Okay, now what dentist would want to do that? The problem is, and that was the problem back then, that there just wasn't a reimbursement level available to pay dentists to make them be interested in working in nursing homes. And the other problem we found that Medicaid residents, because a lot of them didn't have dental insurance or dental services prior to coming into the nursing home, very often had very, very poor oral conditions, had not been to a dentist for many years, and therefore they come into your facility with a mouthful of problems that you're now potentially responsible for. And again, limited reimbursement. And at that point too, dental hygienists were not allowed, they weren't recognized to be able to work independently from physicians. And there were political obstacles too. Let me give you an example. When we published the report from this first study, one of the recommendations was to allow dental hygienists to work similar to what nurse practitioners can do, that they could go into a facility, provide services, and be reimbursed for it. Well, I put this study out and I got a call from the American Dental Association, and the president reamed me up and down. How could I dare suggest that dental hygienists could work independent from a dentist? And it was really a very challenging conversation. I flew out to see him the next day. I actually did a face-to-face with him. And at the end of the day got him to agree that we could put that in there. but he didn't want me to mention anything about them being paid to do that. So the political obstacles back then were really challenging. They've gotten much, much better, but back then were a real source of problem. What some of the key findings are that the Medicaid residents are the most at risk, and primarily because, again, they haven't had a lot of good dental care throughout their life, and therefore they come into a facility typically with a lot of issues, unresolved dental issues that the facility then becomes responsible for. The other finding was that hygienists are needed to provide regular cleanings in nursing homes. You know, finding a dentist back then to come in was next to impossible. And that was my argument with the Dental Association when they challenged this. And I said, well, fine, if you can get dentists to come in and do it, we wouldn't need to bring the hygienist in. But dentists won't do it, aren't doing it, and therefore the hygienist is the logical extension. And that politically, we were able to win that battle eventually, but it took some fighting. We also need to increase CNA's attention to oral care. So that's easier said than done. In a lot of the interviews I did with CNAs, I can't tell you how many times I was told, well, you know, I tried to brush Mr. Smith's teeth, and the first time he spat at me, and the second time he bit my finger, and the third time he grabbed me. He said, I'm just not even trying anymore. And I understand that. I mean, it's a real challenge with certain residents who don't want to have their teeth brushed, or if they're in the early stages of dementia, just don't recognize what you're trying to do. So it is challenging, but it doesn't mean that it can't be done or shouldn't be done. And we need to find ways to improve the ability of CNAs to provide dental care. Now, staffing shortages. In today's environment, every time I do a presentation, I ask the facilities or those present, what's your number one challenge? And 99% of the time, it's staffing. And when staffing is short, as it is right now, dental care is probably one of the first things to get left off the list. There's just not enough time to do everything. So it is a real problem, was back then, and probably even more so now because of the staffing shortages. But one of the other recommendations was we need to get more dentists to come into the facilities. And to get more dentists, the only way to really do that legitimately is you have to pay them. You have to be able to provide an appropriate salary or compensation level, which historically we have not been able to do. So one of the big recommendations that came out of the study and has impacted us today is to develop a private dental insurance program that specifically targets the Medicaid long-term care population. Now, one of the cool things about that was federal law does allow when a Medicaid resident applies or when a person applies for Medicaid, whatever income they have becomes their personal responsibility funds. And that gets paid to the facility less whatever the state allows, the $45 a month or whatever it is. But the rest of it goes to the facility as their personal responsibility funds. And the state Medicaid grant is the difference between what they're able to pay and what the monthly allowable rate is. Under federal law, you're allowed to use those funds, the resident is, to buy medical related insurance. That's how Part B insurance is paid for. And dental insurance falls under that same category. So a Medicaid resident can use those funds and purchase dental insurance. Think about that for a minute. Because they're already paying it to the nursing home, the insurance comes out of that personal responsibility fund, and then the Medicaid grant to this facility gets increased. Bottom line is there's no cost to the resident, no cost to the family, and the facility is still reimbursed at the exact same amount. So it's a win-win-win all the way around from that perspective. Now, there's been arguments back and forth about, well, Medicaid's really paying for that. Well, Medicaid's not paying for that, at least directly, because it's coming out of the personal responsibility funds. Medicaid does end up paying that same amount to the facility. So one could argue that Medicaid is, in essence, putting out extra dollars for the dental care. But a good Medicaid program should pay for dental care. And that's been my argument all along. And that's why I've highly supported these private insurance policies, because they are built on the idea, the concept that nursing home residents deserve good quality care. when we looked around the country for states that were doing good care, there were few and far between. Almost any state you looked at, the only dental care that was provided was what the Medicaid program would reimburse for. And it was basically very minimal things, cleanings maybe once or twice a year, occasional extractions, and dentures potentially, but only every 3 years or 5 years. So it was very limited what Medicaid would pay for. There's a company out of Minneapolis called Apple Tree Dental that's been around for probably about 40 years now. And they started as a nonprofit, and they were reaching out to, it was at that point at least 100 nursing homes. And they would go out and they would provide whatever dental care was appropriate for that individual, regardless of what the reimbursement was. They just provided what that resident needed from a dental care and oral health perspective. And the really exciting thing was they kept really good records. And a PhD student about 20 years ago started taking their data and put together what I consider to be the Bible of what dental care type services nursing home residents need. It did not include things like root canals and caps. And you don't get into that with the geriatric population necessarily, but it had all kinds of services that they need. And it was all covered under this insurance policy. It did dentures basically from the first, it did dentures so they could eat and chew properly. It replaced crowns and other things that they might have had and expanded them. But it provided really a comprehensive array of dental services. So when this insurance policy started to be discussed, the idea was let's model it after Apple Tree Dental so that people get that full array of services that they're needed. So, again, that's what we based the coverage on. Now, I got to tell you, one of the most challenging things I've ever done was finding an insurance company that was willing to write an insurance policy for probably the most adverse selected population you can think about. Because remember, insurance, when you look at an insurance policy, the concept is you have a large number of people paying into something and you have a select group of people who are going to have the incident that's being reimbursed. So it gets spread over a large group. But when you talk about dental care for Medicaid nursing home residents, they're all in bad shape and they all need a lot of care. So they call that adverse selection. So we were trying to find an insurance company that would insure the most adverse selected population you can think of. And by the way, they were Medicaid residents, so they didn't have any money to pay their premium. It took me about 4 companies, and after they laughed at me, I found one that really saw the light, saw the benefit, saw the fact that it could come out of their personal responsibility fund, so they could get their reimbursement, and it worked. So it was great. And it's in about 18 states right now, that policy. So anyway, one of the best things about the policy is there's no cost to the families or the residents. Now, when that first went through about 15 years ago, I remember speaking with the Department of Insurance in Pennsylvania because it has to be approved by the Department of Insurance in each state, and they were questioning the level of the premium. And at the time, I had 7 kids, and my insurance policy for the family, I was paying I think about $98 a year or a month, $98 a month, and this dental insurance policy for the nursing home residents was a little bit over $100. And I can remember the commissioner questioning how that could be such a high number. But think about it. You got an adverse selected population, so a lot of people need it. There's no copay, there's no deductible. They do dentures from day one, and they replace the dentures if they're lost or broken. So it really was a justifiable amount. Even though at first glance it seemed high, it was very justifiable. And it was approved and it went forward. And again, it's in 18 states right now. And again, one of the good things too is the facilities reimbursement is unchanged. They're still getting the standard monthly Medicaid rate for that individual based on the combination of their ability, their personal responsibility funds and the grant they get from the state. And the other good thing about it is because it's an insurance policy and built into the premium, was enough money to pay dentists a reasonable fund, a reasonable amount for their time and efforts. So it was able to attract good dentists to come in and provide care. So Let's talk a little bit about the impact of poor dental care on quality of life and the cost. It's been proven time and time again that poor oral and dental care has can lead to heart disease and a whole variety of other medical complications that cost our system, downstream medical costs, and they shorten lifespan and they impact on quality of life. It can result in loss of weight for residents. And you've probably all seen that in your facilities, particularly if you got a patient with no teeth or bad teeth and can't chew and can't, therefore has difficulty eating. And I got to tell you, I've realized this again coming back into the fold, if you would. Food is one of the most important things for a lot of these residents. That's what they look forward to every day. And meals are important, and not being able to eat is a major negative. So having good dental care, having dentures when you need, all that helps a lot. And I got to tell you, one of my most exciting experiences in this whole dental issue is some of these companies now can have what they call dentures in a day. If ever you had kids that played soccer and you used the molds that you'd put in the boiling water, and then your son or daughter would chew down on them, bite down on them, and they'd make a mouth guard for when they're playing soccer or whatever. Well, the dentists get mad when I say it, but it's similar to that. They get a series of full dentures in different sizes, from very small, medium, large, very large. And what they do is they match the right size to the individual, and they heat them up in a certain way, and then they fold them and they put them in. But they can do a set of dentures in about 2 or 3 hours, which is really amazing. And I remember being with a resident, her name was Mary, and I sat with her while she went through this process. And then I went down and had lunch with her. And she was just so excited to be able to chew her food again and enjoy the meal the way she always remembered doing it. I mean, to me, that was just a very exciting adventure. And she was so appreciative. And, it's just a little thing we can do to make a person's life better. And it's not difficult. So we just gotta try to focus more on these things that help our residents. There's three major models out there that I see in the industry, and each have their pluses and their minuses. The first is when you have a local dentist that's willing to come into your facility and help you. And very often they're a good Samaritan kind of person who they don't necessarily charge, or they charge very little, or charge whatever they can get. They're not even worried sometimes about the Medicaid reimbursement. They're doing it because, maybe their mother was in that facility and they have a lot of respect for the program, or they just feel that need to help seniors. And if you can get a local dentist that can come in regularly, that's fantastic. It really is. But they're few and far between. A more common model that we see is one of these mobile companies that uses Medicaid as their primary source of payment, but then they can also use the OME expenses, other medical expenses. And that, again, they're funds that come out of the personal responsibility fund. So if they spend more money or do things in dental that are more above and beyond what the patient's family is covered under Medicaid, they can get some of that money back through the OME process. It's a lot of paperwork, but they do it. And they typically go into a facility and work from room to room and see the residents in their room and provide the services there. Some of that's good or bad. Some of them, not too many, will set up a dental operative somewhere in your building, typically in your hairdressing room where there's water. But again, that's one model. And the third model is the one that uses dental insurance. And again, the private dentists, they're good Samaritans and they serve the local community. They don't really charge a lot, or they do it for reduced fees. And if you can get them, God bless you. That's my first and best recommendation if you can do that. But again, they're few and far between. The mobile companies that use Medicaid, they can be good, and they are limited sometimes to what Medicaid coverage offers. And they can sometimes go beyond with the OME process. But they go room to room, they do cleaning, they do brushing, they do extractions. Sometimes they'll only do limited work. If it's something more serious, they'll transport the patient from the nursing home to the dentist's office to do anything that might be a little more serious. And a few of them do set up dental operatives, but not too many from what I've seen. And again, difficult cases, anything of an extraction or serious nature, they often send to the office. The one I like the best, quite honestly, is the mobile company that uses dental insurance. And the reason I like these the best is, number one, they have a much broader array of services they can offer. Just for example, dentures. In Pennsylvania, you have to apply for approval for the dentures, which can take a while. And then it's only, I believe, every 5 years at this point. These dental insurance companies, the way they work is the day you begin your coverage, you're eligible for dentures. If you need dentures, they'll make you dentures. And if you lose them or break them, they will replace them. Just a quick aside on that. Most often when dentures get lost, it's because the resident has left them wrapped up in their napkin on the dining tray. One of the best techniques I found years ago from a facility I visited is they offered their dietary people a $25 bonus if they found a pair of dentures wrapped up in the napkins. And the difference is if they knew that bonus was there, before they just dumped everything in the trash, they would just go through and make sure those papers didn't include a pair of dentures in them. Had a really amazing impact on reducing the number of lost dentures. And think about it, if your facility loses the dentures and you have to replace them, that can be $2,000 sometimes. I mean, it's not an inexpensive process. Well, under most of the dental programs, they'll include a set of replacements if they do get lost or broken, which is pretty cool. And again, these insurance policies are based on that apple tree dental experience, which means that they cover a really broad array of services that you're not going to find under Medicaid. And they also come in, they set up a dental operative in the facility. And they can do almost anything and everything that needs to be done. The only time they tend to not do a service is if the patient's medically compromised. If they have something going on that makes the extraction of a tooth there risky or medically dangerous, they won't do it. But most everything they do there. And if they do have to send them out, they pay the specialist or they pay for the cost of that person going out to the other facility to get the work done. And that's something you don't find in any of the others. And again, there's no cost to the resident, the family, or the facility because it's all part of the insurance policy. Excuse me. So the insurance model allows programs to pay the dentist at a competitive rate in the market that they're in, and that increases the supply of quality dentists. You know, again, prior to this, you know, I've seen some facilities who were so desperate to get a dentist that they'd hire anybody that had the credentials, but some of those guys just were not good dentists. I mean, we get good and bad in every level of care, but when the payment was so low and they're relying on the Medicaid model, some of the dentists that were coming in were really questionable. But with the insurance model, you're able to assure that they hire the best dentists they can get, and that's a good thing. So let's talk reality. How are we going to improve dental care in our facilities today? You know, I thought with this dental insurance model and the fact that they usually come in and they do like 4 to 5 cleanings a year and they're in regularly working with staff that it would have had and did have an impact on improving oral dental care. And then COVID hit. And I think we took 10 years back, unfortunately, because of COVID. So we're here today and trying to figure out what can we do about increasing the quality and the use of dental care. And the current staffing crisis is just a really major factor preventing that from moving ahead in an aggressive way. When you're short of staff, you know, cleaning a resident's teeth is one of the first things to get dropped, unfortunately. It's unfortunate, but it's just a reality of today's market. And what about the residents that fight you or don't want to get their teeth brushed or bite or kick or spit? I mean, again, as a nurse's aide, you know, your willingness to work with that person and to really push after you've had a couple of those bad experiences, just not there. And you have to ask yourself, if in your facility, what % of your residents are currently getting their teeth cleaned twice a day? But think about that and be real honest, okay? I asked that because I did a survey over the last couple of weeks, just called a random number of facilities I know, about 12 facilities, and asked them, how many of the residents get their teeth brushed twice a day? And the answer, though unbelievably, they range from 0 to 40%. And 0 to 10%, 15%, that was the more common. It was really a very low percentage. And again, I understand that. I see the challenges every day when staff call out or you don't have enough staff, or even when you have full staffing. The intensity, the acuity of the patients we're caring for now compared to 1981 when I first started as administrator, it's like night and day. Back then, our staffing level was 2.7 hours per patient per day. And today, all this time later, it's still 2.7 hours per patient per day. And yet the acuity level and the types of patients we're caring for is so much more tense. So finding time to brush teeth is understandably a challenge for any facility. So we have the staff shortages contributing to that. Dental care is still just a low priority, unfortunately. There's too many other things going on every day that take our time and energy and our efforts. I don't know if you've been watching this, but Governor Wolf's been proposing an increase in the nursing hours from 4 to 4.1, from 2.7 to 4.1. And while I applaud that, I think we need that 4.1 hours. I have two big concerns. One is these changes are often done by the regulatory side of the house. So you get the change to move up to 4.1 hours, but there's no increase in reimbursement to cover the expense. Back in the 90s, I was on the board of a nursing home company in Florida. They had 42 facilities, I think, in Florida. And the state increased the nursing hours, nurses 8 hours by 1/10 of a point. So I think it went from 1.2 to 1.3. I forget the exact number, but by 1/10 of a point. Okay. And everybody looked at that and thought, oh, that's not too big a deal. But over the 42 facilities they had, it was about a $4 million impact in a single year for that organization. Now, Pennsylvania, if we go to 4.1 hours without any kind of increase, I predict that we're going to see a lot of facilities go bankrupt and go close. They just can't do it. And even if they provide the reimbursement, I'm not quite sure. I know in my facility, I'd be hard pressed to find 4.1 hours staff to bring it up to 4.1 hours per patient per day. That would be very challenging. Here's one thing that's just come out that I think has some potential to help in two ways. This is a new device that a dentist out of the University of Penn created. It's a device to allow you to brush your teeth in a quick and easy way, just two simple swishes back and forth, top and bottom. So it cuts down on the time, makes it a lot simpler. I think makes it safer for nurses' aides to do it. And I have a short video of this I'm going to show you too that just gives you a little better idea, I think. Let's see if I can get to that now. Now let me do that. Okay, up there we go. There it is. I'm hoping you can see that. Okay, and here we go. This is the sorry about that. It'll take a minute. Hope. As you can see, it's a simple device to swish back and forth, top and bottom. It has toothpaste. Oh, we're gonna get out of that. You get the idea. I'm gonna knock that out because it's not doing well. And we'll go back to our slides. Right. Any rate, it's a pretty interesting device, and he's looking for facilities to test it in. So if anybody is interested in potentially doing a pilot with him, please let me know, and I can put you in touch and see if they can't do it. This is one of those areas where I think can have an impact. Now, to give good oral care, dental care in a nursing facility, it really requires two things. One is you need daily brushing for the residents' teeth, and then you need regular cleanings by the hygienist or the dentist. And the two go hand in hand. You know, the hygienist will come in and do a cleaning, and some of the studies will tell you that the cleaning, that only lasts in terms of breaking down the bacteria for a couple of days, and then your mouth is again filled with the same bacteria it had prior to the cleaning. So regular cleanings are pretty important. And with some of the insurance products, I know they do it some of them are 4, some of them are 6 times a year. So that to me is important. The daily brushing of teeth, the only way I think that's going to happen is that you have to make it a priority in your facility. You have to put this out as one of the things, maybe do it as a quality assurance program, but to make it a priority in your facility and push the CNAs to make sure that they encourage them to make sure that they're doing it on a daily basis with every resident they can. As they have a resident that's got problems or that fights them is difficult, that's something you have to look at separately. But the majority of residents you can probably do it with and should have it done. Again, insist that regardless of who your provider is, what model you're using, ask them to come in multiple times a year to do the cleaning for your residents. And then also you want to consider applying to this, he calls it a buzo brush, to be a part of his demo. That would be an interesting way to get started in it. Now, realistically, there's only one problem with the buso brush from my perspective, from a business perspective, and that is it's expensive. I mean, right now, most nursing homes buy a bushel of toothbrushes and a box full of toothpaste, and it costs them very little to do that. These bushel brushes are probably going to end up being 40 to 50 cents each, and from a infection control perspective, it's a one-time use. So it adds a lot of costs. What I'm hoping is that the insurance products, the insurance companies will be able to include that in their premium, and therefore, again, doesn't impact individual families or facilities, but then could be available to the residents. So that's one thought. I just wanted to mention a couple other areas that I think every nursing home should be looking at these days, because these are key issues. One is telemedicine. I can't tell you how important I think telemedicine is in terms of preventing unnecessary and avoidable hospital admissions. And it's a big deal because every time you prevent a patient from going to the hospital through telemedicine, you're generating more revenue for your facility. When they leave and go to the hospital, you can't bill for them anymore. And that could be a significant amount. I'm just finishing a study in Florida of 28 facilities that I implemented telemedicine and are using it. And some were successful, some were not. And the big findings from that study are going to be the operational characteristics of those that were successful and the ones that weren't successful, what was missing, what was wrong, and what needs to be upgraded for any facility thinking of doing telemedicine. Another was a thing called Tango Belt. There's another group locally that's developed this material belt about 1 inch in diameter that goes around your waist. These are for people that are high risk of falling. You've done your medication analysis and review, and you've taken it anyway if it's a trip hazard. You've maybe put them through physical therapy to strengthen them, but there's still a high risk of falling. And the Tango Belt acts like the airbags in your car. If they start to fall, the sensors pick that up and they inflate these airbags around their hip to prevent the fractured hip. Very interesting. They also are looking for facilities to pilot this in. And they have money to pilot it, and they pay your facility and your time and your people that are involved with it. So if you're interested, let me know. That's a really good study. The other one that I've just recently seen I really like is it's called Agnes Vitals Connect. It's a way of, so your nurse aide goes in and she puts the cuff on a person's arm, takes the vital. Well, right now in most places, you have to then write that on a piece of paper and later in the day go enter it in the medical record. This device actually collects the information right from the cuff and then uploads it directly to the medical record. And it has two big impacts. One is eliminates the potential for human error, which happens a lot in recording those numbers. And secondly, it saves your staff a lot of time. I'm estimating probably 3 to 4 minutes per reading, which adds up to a lot over the course of the day. It's not going to let you lay off staff, but it gives your staff more time to interact and spend informally with the resident. And I think that's a pretty exciting thing. This is the Tango belt. There's a video, but I'm not going to put it because I just had trouble with the other one. But you can see as the person stands up and they start to fall, it inflates around their waist and prevents the fractured hip, which is a huge impact. I mean, fractured hips cost our system a fortune. And on top of that, the majority of people die within 6 months of having a fractured hip. So it's a huge factor. That's what I have to offer. And again, I think dental care, unfortunately, given our staffing situation, is really problematic, but it needs to be an emphasis. And unless a facility prioritizes it as a need and encourages staff to really take an effort and do that, it's not going to happen until at least we get some additional staffing support. So that's what I'd like to suggest. And if we have any questions, I'm happy to respond to them.
Thanks, John, for the information. As John said, we will open things up for question and answers. A reminder that you can type any in the chat box. Well, John, you must have covered everything. If we get any questions afterwards, John, we will get in contact with you. Again, thanks to John for the presentation today and sharing this information. And thank you all for joining our webinar. If you have any questions, please let us know. And thank you, everyone. Have a great day.
Thanks, everybody, for attending, and feel free to reach out to me if I can help. Take care now.